All right, we'll get started on the last session. Hopefully this will be the most interesting session of the entire conference, I think, because it's about IBD. Yeah. So we have an all-star faculty to discuss. We have fun cases to talk at those end. So without much ado, we'll get started. My name is Navanethan. I think most of you have probably met me in the IBD Center at Orlando Health, and we have a lot of faculty here. My co-moderator for the session is Dr. Agarwal, my partner at the IBD Center at Orlando Health. She also joined me from the Cleveland Clinic, Ohio. So we are both Cleveland Clinic alumni together. So before much ado, we'll start the session. The first topic is on positioning IBD therapies for ulcerative colitis. I know we have a lot of new therapies coming along every day, for UC at least. So I think we are welcoming Dr. Bruce Sands, who's the Chief of Gastroenterology at Mount Sinai, to talk about this very difficult topic. Okay, welcome, Bruce.
Thank you, Uday, and thanks for inviting me. And you've given me an impossible task to summarize all of UC in 15 minutes, but I'll try. Here are my disclosures. And here are the objectives. I just want people to be familiar with the advanced therapies that are now available for treating UC, and to think about the different factors that contribute to the choice of therapy as it relates to positioning and sequence of these therapies. Of course, we've had the conventional therapies for many years. You know all of these. They're familiar to you. Probably you haven't used very much tacrolimus or cyclosporin. They had their day. I would say there isn't very much role for them, as you'll see. The biologic therapies were the next innovation, really, the anti-TNFs first, which you know, all of these. Then anti-integrin vedolizumab, an anti-alpha-4 beta-7 integrin antibody. And then anti-IL-12 and 23 antibodies, starting with ustekinumab, which blocks both 12 and 23, and then the three more recent innovations, mirikizumab, risankizumab, and guselkumab, which are anti-P19 antibodies that only block IL-23. And then finally, the last innovation in advanced therapies are targeted synthetic small molecules, and these include the JAK inhibitors, which started with the innovation of tofacitinib, which is a pan-JAK inhibitor, relatively unselective, slightly more selective for JAK1 and 3, and upadacitinib, which is said to be JAK1 selective, more recently approved, both for UC and for Crohn's, and the S1P receptor modulators ozanimod and etrasimod. So we'll talk about each of these. And I think what I'm going to say is listening to Dave Whitcomb's talk this morning about how genetics and all these predictive models can tell you everything you ever need to know about pancreatitis and how to treat it, it just gets more and more complicated, unfortunately, in IBD. We have a lot of pieces in the puzzle now, and I do not think that the treatment of IBD right now is algorithmic in nature. It's just very hard to put an algorithm together. So you have to consider different factors, including drug factors and patient factors. The drug factors are what indication? Rapidity of onset is important depending on how sick the patient is. The durability of the response. Aspects of pharmacokinetics and whether you use therapeutic drug monitoring. Whether you need combination or monotherapy. The safety of the drug. Special considerations for infection, cancer, and concerns that are specific to one agent or mechanism. Then with the patient, we have different people, different individual characteristics, patients at different ages, pediatric through elderly, different stages of life. Are they thinking of conceiving? Comorbidities and patient preferences. And then the characteristics of their disease location, disease severity, whether it's early or late disease, the presence or absence of extraintestinal manifestations. And when we're making a decision about treatment choices, all of these things factor in to the choice for an individual patient. And this leads to choices in positioning and sequence. And I think most importantly, considering what did the patient go on before, what worked or didn't work. And in the middle of it all are aspects of convenience, tolerability, and access. And we can't talk about access here. That is highly individual based on the patient's insurance coverage. And there are many different scenarios, just to give you examples of different kinds of patients. In the lower left-hand side, you have a newly diagnosed patient with UC, and he's a man, he has moderate to severe UC, he's failed prednisone, that's it. Someone who's failed a TNF inhibitor, he's older, he has a smoking history, long history of UC, and already failed infliximab. A pregnant patient, not pregnant yet, but intending to start a family, that's going to have different choices. and someone who runs around the world for life, a businesswoman, travels often for work. She has ulcerative proctitis. We have patients who have clearly unfavorable pharmacokinetics. Patients overweight, otherwise healthy, a young person with a severe flare. The albumin is low and has already failed infliximab. These kinds of factors, obesity, albumin, male, these are key factors that lead to high turnover, high clearance of biologic therapies, and this is unfavorable. And then we have patients with acute severe disease. That's a different thing as well. So we can start by, we're never going to see a head-to-head study. That won't happen. But we have network meta-analyses. And for all their flaws and all their assumptions, generally what you can say is that everything works in the bio-naive population. Not all to the same extent, but for example, on the left-hand side, where you see the JAK inhibitors, if you are practicing in the US, which I think all of you are, you will not be using JAK inhibitors in a bio-naive patient or in a TNF-naive patient. So therefore, everything to the right, whether it's ustekinumab, vedolizumab, infliximab, golimumab, ozanimod, adalimumab, and almost certainly etrasimod, and any of the newer anti-IL-23s, all of these do work in the bio-naive population. When it comes to the bio-exposed population, there you do see that upadacitinib and tofacitinib are to the left. Filgotinib is not available in this country, that's FIL. And then you see ustekinumab and vedolizumab in the middle. Patients already failed TNF for the most part, so those are kind of neither here nor there. And some patients with ozanimod who might get ozanimod it might work, but probably not the best choice. So we can think in generalities about disease severity in UC and how that affects our choices. You want to reach for generally the more effective therapies that were to the left of the network meta-analysis diagrams that I showed you in the patients who are at high risk for colectomy. These are patients with more extensive colitis, patients who have deep ulcers, however you wish to define that, younger patients at onset of their disease, patients who have high CRP and high SED rate. That is always an alarm signal for me when I'm treating a patient with UC. Of course, very common in Crohn's disease from mild to severe disease, but in UC, that is a marker of much more severe disease. The moment a patient needs steroids, that's bad. History of hospitalization and history of C. diff or CMV infection, those are more seriously ill patients. You want to reach for the things more toward the left. We can start with the basics and state that infliximab is still a wonderful treatment, and all the anti-TNFs are excellent treatment for ulcerative colitis. This is the UC success study that mimicked the Crohn's disease SONIC study, showing you that combination therapy with an immune modulator, in this case azathioprine, is still a best practice in UC. And so for the patient who really needs most optimal therapy, I will still use combination therapy at least for the first 6 to 12 months before I consider whether I'm going to peel back the immune modulator. Now, in the situation of acute severe UC, historically, we have lots of evidence, not just this study, but others. This is the CISIP study from France, showing that infliximab and cyclosporin, after failure of intravenous corticosteroids, are exactly the same in terms of efficacy, apparently, and of course with better safety for infliximab, as well as a post-induction treatment regimen, which is continuing the infliximab, and there's a whole dance that you have to do after cyclosporin. So we basically don't see cyclosporin used anymore. Acute severe UC almost always is going to see infliximab. So for the TNF inhibitors, just to summarize, the benefits are rapid onset of effect. We're not talking about Crohn's disease, but if there were fistulas, it would be effective there. Proven efficacy in acute severe UC for infliximab at least. Effective for a variety of extraintestinal manifestations. There's an abundance of safety in pregnancy, and this would be true of any of the immunoglobulin-based medications, any of the biologics we used. Therapeutic drug monitoring, at least reactive, if not proactive TDM, is very well accepted and may be less expensive because of the availability of biosimilars. On the con side, all the things that we know from 20 plus years of use: infection risk, contraindication relatively with prior lymphoma, active cancer, skin lesions, contraindication in CHF, patients who have history of demyelination disorders, you need to screen for TB and hepatitis B, and as I said, combination therapy really is still preferred in the first 6 to 12 months. Now, if we look at first-line therapy, however, it may not be your first choice to go with an anti-TNF after the Varsity study, which at least compared vedolizumab to adalimumab and found for the anti-TNF naive patients that actually vedolizumab was superior almost by 10%, which, by the way, is how much more effective adalimumab itself was over placebo in the original studies. For the anti-TNF exposed and failed patients, and this means infliximab exposed and failed, actually it was equally effective, more or less, to give vedolizumab or adalimumab. So that really should have changed our practice, and I think in most of the world it did. And in first-line therapy, we also have this retrospective real-world data suggesting that vedolizumab and infliximab, we're talking for the moderate to severely active patient, not acute severe UC, that there's fairly similar efficacy in terms of clinical remission and mucosal healing. So in my mind, vedolizumab, if you want a safer option, is still very effective. And by the way, it was as equally rapid in onset of effect as adalimumab was. So for vedolizumab, here are the considerations. Excellent safety record, a good choice for patients at high risk for infection, low immunogenicity, likely, certainly, I would say, does not require combination therapy, unlike anti-TNFs. It's a great first-line therapy, good for someone who has a history of cancer, doesn't impair efficacy of vaccination, at least non-oral vaccination, and now there's also a sub-Q formulation available for maintenance. That's new in just the last year. The cons, it's still unclear to the extent to which this MOA is effective in extraintestinal manifestations. It may work for some patients and not for others. There's no proven efficacy in acute severe UC, but maybe you could induce with something like tacrolimus or some other, maybe these days it might be a JAK inhibitor, and maintain with vedolizumab if you wanted something safer. And there are a number of studies exploring this. And I would say the role of TDM is really not at all clear. This is not a very highly immunogenic antibody, so you don't expect to see anti-drug antibodies for vedolizumab. So what about second-line use after an anti-TNF? There, the data don't look as good. Actually, tofacitinib is probably more effective in this real-world study, introducing the idea that maybe after failure of a biologic, not just an anti-TNF, some patients might do well to go to a JAK inhibitor. But there are things that you need to know. Of course, the reason that we don't use JAK inhibitors in first line in the US and why we really can't is because of this study in rheumatoid arthritis patients. And all these patients, this was a post-approval commitment by Pfizer to investigate the safety compared to anti-TNF. And these were all patients with RA who were 50 or older who had one or more cardiovascular risk factors. So clearly a different patient population than patients that we treat with UC, but you can see that the 10 milligram BID dose clearly had a higher risk of venous thromboembolism, DVT, and pulmonary embolus. If you really drill down into the data, the patients who were clearly at greatest risk for major adverse cardiovascular events and a variety of other things were patients 65 and older and who had ever smoked, not just current smokers, but ever smoked. And so those are the patients who I probably would go out of my way not to use a JAK inhibitor for, whether it's tofacitinib or, as we'll talk about in a moment, upadacitinib. Which raises the next question, which is, now we have upadacitinib as well as tofacitinib, which one do we use? There's no head-to-head study of tofa and upadacitinib in UC, but a small amount of real-world data suggests that patients who have failed prior tofacitinib can still respond to upadacitinib. And if you look at all the data in the pivotal trials, it really looks like upadacitinib is clearly the more effective agent. And so there are a couple of studies, really not very big studies, showing you that upadacitinib can be effective even if tofacitinib has ultimately failed in the patient. And I won't spend any time going through these data, just take my word for it that it can work. The other interesting thing going on is the idea of upadacitinib rather than, or maybe after, infliximab as salvage therapy in acute severe UC. And a systematic review found 11 studies of different quality, really retrospective cohorts, case reports, conference abstracts. We're talking about 55 adult patients described in the literature with acute severe UC treated with upadacitinib. Mostly it's 45 milligrams once daily as the dose, 30 milligrams twice daily in one case, with no clear difference in outcome. So if I would do this, I would do it as 45 once daily. They respond very quickly in just 3 or 4 days. The overall colectomy is low, as low as what we saw with infliximab when we're using that. But there are some adverse events. It's impossible to say with this small number of patients if this is out of the range of normal. So as I mentioned, many patients can be high clearance for biologics. So you want to think about small molecules like JAK inhibitors or maybe S1P receptor modulators, which don't rely on the same sort of drug clearance mechanism for patients who have high clearance, meaning they can't achieve high levels of anti-TNF, for example. The JAK inhibitors are an excellent choice. So with JAK inhibitors, they're clearly effective and in fact must be used after TNF failure. They're oral, so that's convenient. Rapid onset of effect, no immunogenicity, so it's a good choice for patients who are prone to developing anti-drug antibodies or might interrupt dosing, and a good choice for those with unfavorable pharmacokinetics. It's no longer for UC. Upadacitinib is now approved for Crohn's as well, as you know, but only useful after TNF failure or intolerance. I would say you're going to hear a talk about pregnancy from Millie Long, but I don't use this agent in pregnancy, and you probably shouldn't. Limited evidence in acute severe UC that's growing. There is a possibility of drug interactions, and be aware the safety issues, herpes zoster, hyperlipidemia, skin cancer, the box warnings that we talked about. So what about the S1P receptor modulators? Here, I think this oral class, and we're starting with ozanimod, is best used as a first-line therapy or at most after failure of one biologic. Here you see data broken down from the ozanimod pivotal trials, the True North study showing you that for induction, failure of one biologic does almost as well as the bio-naive. With 2 or more biologics, you don't see a great inductive effect. That doesn't mean that with persistent treatment, you might not see some patients respond. I certainly have, but it makes this a better choice for first-line use. Etrasimod is the newer agent, and to my eyes, these data look better for induction than we saw with ozanimod. And this is a treat straight-through design, so when you see a third of patients who are in clinical remission at the end of a year, what you see is what you get. And that's a very remarkable result, actually. This shows you the Elevate UC data. This is just a UC 12 data, just a 12-week study. The only difference here was a higher placebo response rate. You still see the same levels of efficacy for the drug. And the one unique thing in the etrasimod development program was they actually studied patients with less than 10 centimeters of active rectal involvement, so isolated proctitis, and if anything, they showed even better efficacy. So that provides a level of comfort in using this agent for those patients. So, excellent safety, actually. This is an immune mechanism that I didn't really talk about, but you don't see increased risk of infections. Convenient oral once daily dosing, best positioned as a first-line therapy. There are a few safety things you need to know. You want to do a cardiogram in the first place to avoid use in second or third degree heart block. Limited data on extraintestinal manifestations, but stay tuned for that. Patients need a fundoscopic exam. Slower onset of effect than a JAK inhibitor, not considered to be safe in pregnancy. And you'll expect to see lymphopenia. That's an on-target effect, but no increase in infection. Now, finishing up to summarize with the anti-P19 antibodies, this is one slide that summarizes as much of the induction data as possible. On the top are the data for ustekinumab from the UNIFY studies, and you see the drug effect, you see the placebo effect, and the delta on the right-hand column. Now compare that to mirikizumab, guselkumab, and risankizumab, now all approved for the treatment of UC, and you can see some differences in bio-failed and bio-naive, but overall, all the anti-IL-23s look more or less similar. It looks like guselkumab and risankizumab have better efficacy than apparently mirikizumab for the bio-naive patients in induction. And in maintenance, the long-term data for these drugs is really excellent. We tend to see lower rates of loss of response. So a lot of good things about the anti-IL-23 antibodies. Great safety, great choice for patients at high risk of infection, low immunogenicity, doesn't require combination therapy, could be used as a first-line therapy or a second-line biologic. Most of these are sub-Q dosing after IV load, but now we actually have data that there can be, at least for guselkumab, a sub-Q load and then sub-Q maintenance. And it's a good choice for patients with psoriasis, obviously. We don't know about TDM. We don't know very much about extraintestinal manifestations other than psoriasis and psoriatic arthritis. We'll skip Crohn's disease. No known efficacy in acute severe UC as yet. And we don't know about the safety with live vaccines, but probably safe if I had to guess. So further considerations are patient characteristics, when it's favorable to use or not to use these drugs. So you can look on the left-hand side. I've sort of exceeded my time, so I'll just present this to you. Take a picture if you wish. But there are specific scenarios where you might favor one class or over another, just because the drug might work for that particular comorbid condition, or because there's a relative contraindication because of the comorbid condition. So how do we solve the puzzles that I presented to you at the beginning? Newly diagnosed patient, great patient for vedolizumab or anti-IL-23 potentially. Failed TNF inhibitor, could be anti-IL-23. Pregnancy, TNF inhibitors, vedolizumab, anti-IL-23, basically any of the biologics a good choice. Someone who's running around, oral is better, but this is treatment naive, so an S1P receptor modulator. Unfavorable pharmacokinetics and failed infliximab, that translates to me to upadacitinib. In acute severe disease these days, it's going to be infliximab or potentially still an off-label use, upadacitinib. So in conclusion, the choice of therapy really is not algorithmic anymore. It's really tailored to the patient. We may get back to a point where we get to algorithm, but not yet. All the drug classes are effective in first-line use, but JAK inhibitor is not used first-line in this country. After failure of a TNF inhibitor, you should be thinking about upadacitinib or an anti-IL-23 antibody. And for acute severe UC, I would consider infliximab or upadacitinib. So thanks for listening, and thanks for inviting me.
Thank you so much, Bruce. I know it's a very hard topic to summarize. Thank you so much. It's great. I welcome my co-moderator, Dr. Agarwal, to introduce the next speaker.
All right, I'd like to introduce Dr. Marla Dubinsky as our next speaker. I personally have learned so much from her, so I'm very excited for her talk. She is the Chief of Pediatric Gastroenterology and co-director of the Susan and Leonard Feinstein Inflammatory Bowel Disease Center at Mount Sinai. So thank you, Dr. Dubinsky, for joining.
Thank you so much for inviting me back. You all could see why we all steal Bruce's slides, because he's the best slide developer on the planet. So Bruce, you'll see some familiar looking slides when we talk about combination. So Bruce sort of walked you through the complexity of positioning a single therapy by definition. Now what we're going to talk about is what I think the future of IBD is really about: combination advanced therapy, which is the idea that IBD is much more complex than one pathway in a disease that has north of 300 genes, multiple microbial influences, and multiple immune responses. So we're really showing the tip of the iceberg when we talk about monotherapy. So we talk about the idea that, and you're going to see this, the therapeutic ceiling slide, I guarantee you, Millie, #1 slide at AIBD this year. No longer the graph of what happens if you don't use effective therapy early. It's the idea that we've reached a plateau, that despite the amazing therapy that Bruce noted, we really have hit a ceiling. And that the monotherapy plateau, which could vary up to about 50% at the end of a year, regardless of what happened, a lot of the study designs, you have to actually look at the way that the designs were to actually tell you the net remission at the end of a year, and they're pretty similar. We do believe there's this concept of mechanistic failure, and I would venture to tell you that's probably more so in a TNF than it is in a non-TNF, and I'll show you what that means. Also, possibly the way we use them in terms of additive, or Bruce, as noted, positioning. Maybe we need to position them together and or sequentially in terms of what we understand about the biology. And for me, managing ex-gut, meaning understanding the biology, particularly in multiple other immune conditions that Bruce showed that slide. I'll re-show it in the context of combination therapy, and also, as I noted, multiple pathways. So the nomenclature really, we know combination therapy typically in the traditional way, the way Bruce also presented it, which is the idea of thiopurines plus anti-TNF. That has pretty well been our nomenclature. Now there's also the idea of dual biologic, dual targeted, and then advanced combination therapy, because mostly in the clinical trials, what you'll note even, TNF failure or bio failure or bio naive, that terminology is becoming advanced therapy inadequate responder. Like, we're making it more and more complicated because we no longer just have TNF, we no longer just have biologics, we also have JAK inhibitors and small molecules. So that is why the terminology is also changing. So as noted, as we go from the traditional way of describing combination therapy, as I just noted, to really thinking about how we're advancing the combination therapy and whether or not it's a biologic plus a small molecule, which is pretty well where a lot of the work is being done, as well as dual biologics, which is combining, for example, a 23 with a TNF, and that's the duet study that I'll remind you is happening, as well as I don't think we're as advanced in two oral small molecules. There really hasn't been until some early phase clinical trials, particularly in the JAK family. There's looking at combining different mechanisms in the JAK inhibitor family, and we'll see how that evolves over time and whether the safety allows us to combine two oral JAK inhibitors depending on the safety profile, of course, because it is quite a widespread anti-inflammatory or immune modulatory effect. So again, the way we talk about it currently, if we look at induction, which is really where I think for us, the magic is really where it has to be, is that if you don't get into maintenance in the depth of remission that you need, or address that very early biologic processes that are probably multiples, I'm not so sure sequencing is going to be as effective. That needs to be tested. So the add-on therapy, where you start with one and then you add a second, that would be add-on. Simultaneously, co-induction, as noted, started both together, and then sequentially following the biology, maybe we'll get to a point where you start with an anti-TNF, for example, and then you go on to an IL-23 as an example of possibly a way to do it. And then in the maintenance phase, do you actually continue combo throughout, and this becomes their treatment strategy, expensive, probably a safety hit, versus induce with both and then pull off probably one that has a higher safety profile, and then continue with one that has a much safer safety profile, versus also using one intermittently. Now, we can't, Bruce talked about immunogenicity and spoke about the idea that the small molecules, for example, and maybe even the non-TNF biologics have very low immunogenicity, so can you use them as like pulse in substitution for corticosteroids? Can you use a JAK as an intermittent rather than steroids? And I think that's where a lot of us are interested in the ability to be on a, what I call a platform drug, which means the base. And you could add stuff to your platform drug as long as it has a great safety profile and that there is, the combination makes sense. Bruce already talked about what we say our standard or our conditional, one that we're used used to talking about combination therapy standard. And at the end of the day, TNF is a very immunogenic drug. We understand, particularly in adults, I think any of us who also manage young people, young adults, young children, we stepped away from combination therapy in 2006. So we had to come up with a lot of creative ways to keep children and young adults who are at risk for malignancy with combination therapy. And what we understood from the SONIC trial, which as a reminder, as noted, was infliximab alone, infliximab plus azathioprine or azathioprine alone, just to throw in for good measure, is the idea that maybe it has nothing to do with Imuran or azathioprine adds some sort of mechanistic advantage, but the feeling is that it reduced the anti-drug antibody rates against infliximab and kept the drug concentrations up at what we call a therapeutic level. And so the concept is that in drugs that we have challenges around PK, and in adults in particular, there's still an appetite. I would venture to say you don't need to do that anymore if you just get a drug level early and optimize the drug, that you actually don't need to put anybody on a therapy that increases the risk of cervical dysplasia, skin cancer. I mean, it's just not necessary anymore. And so Bruce knows that him and I we are separated by an office wall on this exact question. And I'd venture to say in UC, where PK is a little bit more complicated, I understand the benefit, but in Crohn's, I think we're exaggerating the need for concomitant immunomodulator. And as noted, they don't need combo forever, so sort of a halfway point, sort of Switzerland between Bruce and I, the idea that maybe you can actually remove after a limited period of time. And actually, Severine, I talked to her a couple weeks ago, and I said, are you still using in Leuven? And she said, after 6 months, we stopped the combination. We feel their drug level is stable. They haven't developed immunogenicity. And then the idea that additive because of the infections, and also the notion that maybe you don't need full dose. You don't need thiopurine levels that were originally thought to be 250 and above to get a therapeutic level, that there's a lot of work showing that even a level of 100 or 125. So you can use a lower dose of a thiopurine if you're going to go down this path. And also, as noted, there are ways for us to understand people are at higher risk of developing antibodies, and that really is an HLA that is available commercially through Prometheus. You can actually do it before you start to know whether your individual is at really high risk of antibodies, just knowing that 1 in 2 people who walk in your office are positive for this HLA. So I think simplicity-wise is maybe I don't do the test and I just treat everybody with a combination, or measure drug levels before the 3rd infusion, make sure it's therapeutic, and then you don't need combination. So it's really 2 paths that you can go by. Again, in peds, we don't use combination. So as noted, and actually Bruce was one of the first, and look at the date. This is 2007. That's how old he is, that it actually said back in 2007, where he was combining TNF with natalizumab. What is natalizumab? Probably don't know it much anymore in IBD, but one of the more effective therapies for Crohn's, I would venture to say, but it's approved for multiple sclerosis, but was associated with progressive multifocal leukoencephalopathy, and therefore really isn't used in the IBD space. It is an integrin, and then vedolizumab came on the scene thereafter. And so what Bruce was noting is that we didn't see a reason to combine these 2 pathways. It doesn't mean that it may not be helpful in other combinations, but particularly in this scenario, TNF plus alpha-4 was not really helpful, and also just noted that it was tolerated. It didn't change the safety profile, but it has to work for us to actually take advantage of the safety. Explorer is interesting. This is the brainchild of Jean-Fred Colombel, who really wanted to knock Crohn's patients off their feet right from day one. I'm going to combine an integrin, so this is vedolizumab, plus adalimumab, plus methotrexate. So instead of using thiopurines or azathioprine, there's been a lot of work in the rheumatology space, as you know, and I think we've caught up a little bit as another way to decrease antibody formation and improve the drug concentrations was to substitute with methotrexate, and that's what we did in peds actually, because there wasn't really data to suggest that metho plus a TNF was harmful in the same way when it comes to malignancy, although that could be debated in pediatric onset IBD in particular. So a lot of us moved to TNF plus metho, and then we started getting on the optimized induction therapeutic drug monitoring train. So here, what was shown is that, truthfully, outcomes were improved indeed when you sort of hit the patient up front with all and then removed, believe it or not, removed the TNF. So this idea of what I was saying, that platform drugs are what we consider the safest maintenance therapy, which would be an vedolizumab or a 23 or IL-12 23 for now, we don't view TNF as a platform drug where you can just add a whole bunch of other things to, because the safety of, for example, a JAK with TNF, high-level TNF, it precludes it may be phenomenally from an efficacy perspective, but for now, that is not a list of combination therapy, but it is more so with the integrins and the 12-23s or 23s. And here you could see that although there were high rates of treatment-emergent adverse events, which, by the way, in clinical trials, table 2 or whatever the safety is, you always see 78 to 80% adverse events. Then you have to go into really treatment-emergent serious AEs and infections and serious infections, because that's really what we're talking about. We're not talking about the odd event. By the way, in a clinical trial, if you have anything that is less than 1,000 really, or in a clinical trial, you're not going to see an event if it's rarer than 1 in 1,000. In any clinical trial that is published out there, you need a lot of follow-up, a lot of exposure to see rare events. So here, looking at serious infections, about 3%. That's sort of what we look at in clinical trials. Perhaps the 23s are a little bit less, and Veto on its own is probably a little bit less, but overall it wasn't like you've tripled or quadrupled the serious infection rates by combining a TNF with Veto. Then, besides the fact that that's all we had at the time as being the rationale, now we are emerging in a time where technology has been updated. Granted, this is animal data, but the idea that perhaps there are multiple pathways, multiple biologic mechanisms happening in tandem, that J&J sort of took on the concept of combination therapy with combination biologics, noting that 23 and a TNF may be the right next step, is that you've got a whole bunch of pathways, gene expression, that are helped by just TNF, that are helped by just 23, and then imagine if you can combine those that are really not hit by each one of them alone. And that was the concept behind really the Duet study and the Vega study, and I'll show you that in a minute. So there was a rational reason, and that's because of biology and gene expression. And then you go to this idea that there may be sort of this resistance or refractoriness to mechanisms over time. And this is actually published in 2018, and I think it's Raja's work has really become much more mainstream because we finally see that in clinic, right? He was like way before what we were seeing clinically, that over time, people were getting these weird immune responses. They stopped responding to TNF. They were getting psoriasiform dermatitis, all these Th2 type of EoE, eczema, like weird sort of different biologic processes turned on by probably, I've run my course on TNF and my biology is switching. So this idea that over time, particularly with TNF, you get this refractory nature, and guess what overexposed? 23. So maybe it is right to say we should combine TNF with 23 or sequentially start with a TNF, then go to a 23. But Vega study, which was looking at gasilcamab, which is otherwise known as Tremfya, which is approved for ulcerative colitis, plus golimumab, which is a drug that I know many of us do not use, don't even know it's available, not heavily marketed, but that is a sub-Q TNF for ulcerative colitis. Symphony is the other name, just in case name recognition, because we don't typically see much of it. And it showed that when you combine both, up front, you did better than each of them alone. Fantastic. Concept of simultaneous versus it on its own, and really, no matter what endpoint, that's what we showed. Now, Does that make sense biologically? And what we are uncovering is that, yes, there is a biologic mechanism for our understanding that diseases that happen outside the gut follow the biology of within the gut. And we know that from psoriasis and the overlap of IL-23, IL-17. There's a reason why drugs like risankizumab and guselkumab and mirikizumab are not approved for rheumatoid arthritis. That's because IL-23 is not a major part of rheumatoid arthritis. That's why there's different types of arthritides that we don't even understand the different biologies. There's a reason why people do well on certain drugs or not, and that's because it's all about the biology. Bruce showed you sort of the pink nature of it and in blue on his slide, and then he showed the contraindications may help you drive biology. This again shows you across the board, these are our current therapies and how, if you have a disease outside of the gut, that should be driving your sequence. And I believe that really the idea that you need to understand why drugs are also approved in other disease states should give you a window into the biology. So then we have meta-analysis that have looked at combining various combinations of biologic therapy, and actually this slide shows you all of the different combinations that have been looked at, and this was published in 22, the meta, and everyone says, well, what about the safety? And truth be told, there wasn't really a big safety hit on a lot of these combinations, and what I tell my patients is that when I'm combining a whole bunch of stuff, I said I am able to add to a 23 or an integrin, for example. And then we also publish in pediatrics, listen, we've got 2 drugs approved for anyone under the age of 18 in a disease state that is more severe than adult onset IBD. How are we able to make sure that kids don't go to the operating room or that kids are treated correctly, because pediatric IBD becomes adult IBD pretty quickly. And so the idea is we have to be creative. So we do a whole bunch of stuff to keep kids out of the operating room. And so what we do is we use a lot of combination therapy, and Bruce would know, he would always come into the room when we're in clinic on Mondays, and he's like, are you doing that? And I'll be like, yeah, here's the paper. We actually do that. That is actually what we do, and we've combined a lot of different ways. But what I will tell you is that when we added a second drug and tried to remove the JAK, that was pretty well what we tried to remove, almost invariably we had to go back on it. So it doesn't look like withdrawal is possible when you're adding a JAK to a baseline Vito or 23. Another pediatric paper out of Europe, which showed similarly that it wasn't until kids were on combination therapy that they did better. And the most common combo they used was actually Vito plus a TNF. So again, we're being very, very assertive with kids because of their outcomes. Duet, I mentioned, that is the current study in Crohn's and UC, which is combining golimumab plus guselkumab, 2 Gs, and it's in Crohn's and ulcerative colitis in biorefractory patients or bioexposed patients. These are not naives that are getting combination therapy. The other study, which Millie and I were just talking about, vedolizumab, Takeda has acquired upadacitinib and are adding it to Vito for Crohn's disease. Genius. Not even AbbVie is doing combination therapy of their own drug. But instead, Takeda says we could probably make Vito better by adding a JAK inhibitor, and they're probably right for Crohn's disease. So strategies for maximizing benefit and minimizing risk. Patient selection is everything. You really want to identify those patients with other ex-gut manifestations, patients with more refractory disease, and really be able to optimize the therapy. And of course, we need to always balance that with safety. But as I noted, we aren't seeing incremental safety negative impact when you add it to either a 23 or an integrin as your base platform. So, combination of conventional, as we know, has a long history. Sonic, as I noted, changed the paradigm. Combining agents with different mechanisms may help. Agents with novel mechanism of actions or gut restriction may enhance safety and efficacy, and we need better ways to identify rational combinations in the future. So thank you.
Thank you, Marla. It's a great discussion. We'll have more discussion towards the end of the session. Now I'd welcome Dr. Shen to talk on endoscopic management of post-surgical complication IBD. Bo is the director of the surgical center up in up in Colombia. He's my mentor from fellowship. It's always a pleasure to have you, Bo.
Actually, thank you very much, Uday. The best part of enjoy come this meeting, I collect a lot of the pens. Very good pen. Thank you. So I really truly enjoy the talk of the Marla and Bruce, and later on Millie. As the whole purpose of the medical therapy is try to avoid surgery. But sometimes the surgery is not avoidable. So then it's the endoscopy. Endoscopies that play a role. So over the years, Uday and I and a bunch of the others updated that list. So what's the interventional IBD about? What's the indication? Stricture, fistula, abscess, bezoar, foreign body, blocking luminal lesions, FMT, and IBD surgery-associated complications, and the colitis-associated neoplasia. The list goes longer and longer, but today is the focus on the number 4. How do you use the endoscopy to manage the IBD surgery complications? So here is a bleeding. So if you have not dealing with your surgeon often, often they have to. Why? As endoscopist, as a GI, you hardly see these things. Why? Because the surgeon, what happened within 30 days after surgery, if there's a bleeding, what do? Interventional radiology. Or they bring the patient to the OR and then reoperate. The problem they have a concern. So if you say a fresh anastomosis, you put the scope there, and there's a chance the scope can disrupt the anastomosis they're worried about. That's why when you do the endoscopy, be very careful. Minimal air insufflation with the CO2. So far we have 18 cases, no disruption, no perforation, but the bleeding control the result is pretty good. But when you do the anastomotic bleeding control, the best tool is mechanical. Use a lot of the clips, and there's this the hemostatic gel is very good too. We also use 50% of glucose. Only 2 times we use APC and epinephrine, but both of them didn't work. So try to help your surgeon, and then really after that you can let most people can avoid surgery, avoid the interventional radiology intervention. So here is a classification of the IBD structure. So the IBD structure, important one is number of the structure and the location of the structure and the length of the structure. And then based on the underlying is the anastomotic structure and the primary structure. Typically, anastomotic structure works better with the endoscopic therapy. Now, so it's like you have a gold hammer, and not all the things like a nail, right? So if you have a structure more than 4 to 5 centimeters long, you send it for surgery. If any structure shorter than 4 to 5 centimeters, especially the best structure you can handle is called side-to-side anastomotic structure. Typically, it's 1 centimeters and to 1.5 centimeters. Those patients respond to the therapy the best. Now, how do you define the structure? Our definition, because Uday and I were always sort of like we are called a licensed plumber, because we use a tool to measure, they say, it's a structure, not a structure. Not as fancy as the radiology, not as fancy as the pathology. So if you find the lumen is narrowed, so that means use a pediatric colonoscope or EGD scope. If you cannot pass a scope through it, or you pass scope through it with the resistance, then we call it a structure. Those patients may not have the pre-stenotic dilatation. But sometimes the structure is so thin, then you can use XP scope, MP scope to measure it, pass it. Now this is tell you about like sometimes you call by your radiology said, oh, there's a long structure. You know what? When we do the scope, actually it is the length. The radiologists quite often overestimate. So look at this anastomotic structure in the CT scan, in the gastrographic enema is about 5.5. But when we do the scope, actually it's only 2 centimeters. So now we don't have the happy medium. So here comes the tool. This is called endoflip. We borrowed from the esophagus group. We use this one to measure the structure. But disadvantage for this endoflip, because you can't pass this condom-like the balloon through the scope. You need sliding by the scope, and then they use the raptor to drag down the tip of the balloon, the measuring balloon, to measure the structure. So actually, they're pretty accurate. You can do the anal rectal ring structure, and then what's the technical success? Where's the technical success? If the patient has a tight structure, you cannot pass through it. After the treatment, you can pass through it. We call it technical success. Or the patient had, before the surgery, you have to push the scope, but there's a resistance. And then after your therapy, endoscopic therapy, you can pass through that without the resistance. We call technical success. Now, sometimes Uday, and then we have the interventional IBD group, so self-confident. Okay, with less balloon dilatation, the patient's structure. So this is the patient we dilated to 13.5 millimeters. So happy, but you know what? When we measured with this balloon, we only got 8. That means the balloon dilatation, mechanical balloon dilatation, you sort of get a 10 millimeters, you make it only get a 6. So that's why we need a better tool to measure the structure, especially after therapy. Now, there's a dilatation technique. You can use, now we call it a bare balloon, just the regular balloon, typically widely used like a CRE balloon, which is just to stretch the structure. And then balloon dilatation, the IBD structure, so that everybody feel comfortable to do that. The goal, it is like you try to reach the 18 to 20, sometimes we need several sessions. Now, when you do the balloon dilatation, left side, it is the anastomotic structure. Right side is the primary structure. You see as compared with the surgery. With the surgery, resection, reanastomosis, you see the curve is closer when you have an anastomotic structure than the patient with the primary structure, as shown on the right side. So the anastomotic structure respond better for the endoscopic therapy. Now, the people always ask a question, if you dilate the structure, is any rule for intralesional injection? As no rule with no use for the intralesional injection. How do they measure the long-term success? So we set up the long-term success. It is the surgery-free survival or re-intervention-free survival. Now, there's a drug-coated balloon coming. So the surface of the drug is a paclitaxel, same drug used for the cardiac, for the urology, for vascular. So the stent and balloon is so this is the technique now on the clinical trial. Basically, you have the same drug, same balloon, and coated with the drug. So this is before and after. We have the stretch. You can see the efficacy of the dilatation, especially useful for the people with the angulated structure. So now this is the study we did in the Central America, and it showed the efficacy. And then we submitted this article to, it's a PK study to DDW, 25 patients, and half of them the Crohn's disease, and then 1/3 of them are pouch-related, and some other benign condition of the pouch. You can see that as compared to the frequency of the dilatation, then after that, with the drug-coated balloon, you can see the p-value here. So now that we are running a randomized controlled trial for that. Now, before there's a drug-coated balloon available, is there any other tool? We use a needle knife structurotomy. We use IT knife, the insulated tip of the knife structurotomy. And sometimes we put the clip there to open after the treatment. We put the clip to the area we treat. We call it endoscopic structuroplasty. And then sometimes the structure is so tight, we use a mechanical structurectomy, basically use the tool to remove the structure. So now here is the comparison between the electrical incision, that means structurotomy, / structuroplasty versus a surgical resection and anastomosis. You can see the two curves are crossed. So for the anastomotic structure, I think the surgery with the resection and anastomosis is as good as the endoscopic therapy. These two conditions the efficacy is comparable. But important one is the complications. The complication, mainly endoscopic complication with the knife therapy, is a bleeding risk. But as compared to surgical major complications, 32%, that include anastomotic leak, anastomotic bleeding. So now we have a tool. We have the hemostatic gel. And in my estimate, you may cut down the post-procedure bleeding by 90%. So sometimes we call staple may be the culprit. So if you have a tight structure, not respond to the endoscopic therapy, either with the balloon, with the resection, with the electro incision, if you found a dislodged staple like this one, we remove it, and then the picture number 4 shows the resolution of the structure. Sometimes the people have, especially small bowel to large bowel, anastomotic structure, there's a prolapse component. So you treat the structure and use a banding, mucosal banding, the small bowel prolapse. Now, another one is commonly happened in the people with the anastomotic leak, for the people with the Crohn's disease, and then even like a structural plasty side, it can have the structure too. So surgical structure, especially in the inlet and outlet. You can do the endoscopic therapy, either use balloon, use knife, etc. Now, this one, I show the picture, So how do we overthrow dictatorship? Dictatorship here is the presacral abscess, as shown in the middle. You can have external and internal, right? I think that if they internally overthrow the dictatorship, like the Mr. Bashar Assad, right? So internal overthrow is always easier than external. So that when you have the abscess there in the presacral space, there's a way to internal drainage, and the way is external drainage, right? External, the surgeon put a mushroom catheter there. Internal drainage, we just put a pigtail stent there. What's the external force? What do you do? If you put the stent, put the mushroom catheter drained by either by surgeon or interventional radiology, you may have the risk of intercutaneous fistula, very hard to heal. Versus you can do this internally. If you have an anastomotic leak, used to be the surgical community called Endovac. The Endovac, unfortunately, we are not available in Endovac, but you have the pigtail stent. You put the stent there. If they make the abscess worn off, if not worn off, 2 weeks later, you change it. Over the stent to change the pigtail stent is easier. And then when the abscess cavity become mature, wore off, then you do the sinusotomy. So here's the sinusotomy when we have this, the ileal pouch. Anastomotic leak is pretty common, at least 5%. Now you cut the wall between the presacral sinus and the pouch. Basically incorporate the sinus into the bowel loom. You can use the same technique to treat the anterior, low anterior resection for rectal cancer. Same concept. Now this is we do the before and after sinusotomy with a gastrographic enema. Now here is, you can see, this is a sinus, is the left upper quadrant. You use a knife to cut through it, put a staple there, clip there, and then later on, is incorporate the sinus into the part of the pouch. So even we compare the surgical and the redo with endoscopic therapy, the up curve, the endoscopy, low curve is a surgery, right? You can see them numerically, the endoscopy treatment, they have advantage. The plus, this maybe it's cheap, right? In the endoscopy therapy, Uday and I have done this probably multiple times, hundreds of times, right? You can see this, the endoscopy procedure is 30 minutes, and the surgical procedure is 3 stages. Especially second stage, the patient in the OR is 6 hours minimum. So you save the patient money and deliver the safe and effective procedure. Look at the complication rate with the endoscopy therapy, with the surgical therapy. It's hugely different. But not all the sinus you can treat it by the endoscopy. So especially some of the sinus, we call L-shaped sinus, respond the best. Now, next topic is when I'm dealing with the pouches, what disease I hate most is called the pouch vaginal fistula. Used to be, we think it's like if the late onset of pouch vaginal fistula, more than 1 year after the stomach closure, they said, blame is a Crohn's disease. Not necessary. So here is the picture I borrowed from my mentor, Dr. Fazio. Basically, some of the new surgeons maybe do the staple technique. When you put the staple head together, they trap the posterior wall of the vagina into the staple head. They call the leading to the anastomotic leak, and they cause vaginal fistula. Now, how do you repair the vaginal fistula? Every young surgeon wants to say, there's a hole, I can repair it. Be very careful if you repair failed and the hole become bigger. So I told all my patients, if you try to repair the vaginal fistula, you need a second opinion and third opinion from the different surgeon, because quite often you repair, it lasts 2 or 3 months, and then hole become bigger. I have the largest one, the fistula, you can put a finger through it, repair 14 times. Okay, so this is the cell therapy, right? Stem cell therapy. So lasts 6 months, and then still the fistula. Very hard to treat. So we don't know if there's no very effective medical therapy, no very effective surgical therapy, no very effective endoscopic therapy. Now we blame surgeons, right? Why this vaginal fistula started? So there's 2 kinds of this surgery when we do the anastomosis. Left side, we say the stapled anastomosis without the mucosectomy. Right side with a mucosectomy with the hand-sewn anastomosis. So in the middle, there's 2 centimeters I showed here, we call cuff. Cuff is like a DMZ zone, demilitarized zone between South Korea and North Korea. So there's 2 countries don't like each other, but there's no border crash. But if you don't have the 2 centimeter cuff, look at Ukraine and Russia, right? So Mr. Putin, they invade things because of no quotient zone. So that's why the NATO and then what is it, UN peacekeeping force should be like established 2 centimeters. Same thing to the medical therapy there too, right? The endoscopic therapy. Now here is the major article. So I have a collection now, 26 patients up to now. So with the people with the vaginal fistula. I'm looking for what kind of mucosectomy was done, not the mucosectomy done. Actually, majority of them, so the 75% of them had mucosectomy. So these are the things that I talk to my patient. If you need the pouch surgery, if you do not have the precolectomy dysplasia or cancer in the rectum, save the little bit of rectum. So without the mucosectomy, DMZ zone. Okay, now staples. These things are hated. So look at the staple in the front wall of the pouch, right? The next door, about 1 centimeter, is the posterior wall of the vagina. These things can erode, later on cause vaginal fistula. When we see this one, just remove it. Okay, and also prolapse can cause vaginal fistula. You can see the meatball here, prolapse, and at the corner between the prolapse and anastomosis, there's a lot of moist, a lot of stress, and later on cause the fistula. So the prolapse, we have used the endoscopy way to lift it. Now, sometimes the prolapse also has a structure, right? If you look at the blue arrow, this is the vaginal fistula. At the meantime, has the anastomotic structure. Then you treat the structure, let the stool flow better, and then decrease the risk of the moist and the fistula formation. So a couple of slides about evolution of interventional IBD. It's actually started a pouchitis clinic. We use the endoscopy to treat pouch complication. Then we involved this endoscopy to treatment of the various complications, IBD or IBD surgery related. Now we have to move to the 3rd stage. Actually, we apply the same technique to treat the colorectal surgery associated complication. So we have a series of books published if you're interested. So opportunity and the challenge. We still have the issue of how to differentiate between the inflammatory fibrotic structure, maybe intestinal ultrasound, and then we need a better structure measuring device. We still need to understand more about the etiology of an anastomotic structure, and then we will compare the regular endoscopic balloon dilatation with other endoscopic modality. The drug-coated balloon may be held in the future, and maybe we can do the combination therapy with the structurectomy, structurotomy, structuroplasty, and then with intraluminal management of the anesthetic leak and the complications. So here's my last slide. The future perspective of the interventional IBD, we can extend to the anorectal region to even like interposed colon in the esophagus. Regarding the depth, we are involved with the mucosa, submucosa, and even a third space. And regarding the technology, we are looking for the new anti-fibrosing agent, either systemically or topically. The cell therapy, AI. Thank you very much. Thank you.
Thank you, Dr. Shen. I have the pleasure of introducing Dr. Millie Long. She's the Vice Chief of Education and Director of the GI Hepatology Fellowship at University of North Carolina, Chapel Hill. Thank you, Dr. Long, for joining us and giving us this presentation on pregnancy and IBD.
Great, thank you so much for that introduction. I always love visiting here. I actually trained with many of the faculty at Orlando Health. I still credit Cheyenne with the fact that I got into GI fellowship many, many years ago, so it's lovely to come back and visit. I was tasked with, over the next 15 minutes, teaching you about the management during pregnancy, from preconception to peripartum. And there are some new data here that I think hopefully you'll leave with some good action items for your practices. These are my disclosures. So just to set the stage, I do think pregnancy is a really important topic. We're gastroenterologists, of course, but most of our patients with IBD are actually diagnosed during the reproductive years. And in fact, multidisciplinary care, meaning us involved with OBGYN, is really important to optimize and have the best outcomes. And really, not only patients, but some providers are very fearful about treatment during pregnancy. Even to this day, I have to advise my patients, sometimes their OBGYN will be telling them that they need to stop their therapies. So we really need to be very clear and consistent with our messaging and really provide our patients with the appropriate preconception counseling. And when we look at data, it's really the worsening IBD activity that is the greatest predictor for poor pregnancy outcomes. So, over this 15 minutes, we're going to talk about the importance of disease control. We'll run through IBD medications, which we can and can't use during pregnancy. We'll talk a little bit about available resources to help to counsel patients. And then I have a few take-home messages from the recent Piano Pregnancy Global Consensus. You all are seeing this first. This will be published in the first part of next year. That really came together for some take-home recommendations surrounding management of pregnancy. So when we think about the perception about reproductive health among women with IBD, there is a lot of misconception. Almost 2/3 of women have multiple fears, and that counseling is really positively associated with women actually pursuing pregnancy, and it's inversely associated with patients considering voluntary childlessness, meaning they never even think that they can get pregnant, so it's not even on their radar. And when you look about this whole list of concerns, many of these can actually be addressed in a singular preconception counseling session. So really, we can take away these fears for our patients. And preconception counseling makes a huge difference for patients with inflammatory bowel disease. This is actually Marla's work that looked at preconception counseling and a number of pretty hard objective outcomes where you see improvements in folic acid intake, smoking cessation. They did not stop their medications, that their disease activity was better controlled. These all influence outcomes for our patients. When we think about preconception planning, I would argue that the first thing we need to do is for all of our female patients, ask them about pregnancy plans, fertility. I actually really ask everyone from my 17-year-olds that are transitioning up to me to my 50-year-old patients who kind of look at me and say, no, I don't want to have another child. But I really think that we need to know what their intentions are and really ask as we're making treatment recommendations and coming up with a treatment plan for them. So if they say yes, we really need to do a disease evaluation. We need to make sure they are in remission. They need to be steroid-free. We need to understand where they are from an endoscopic, potentially imaging perspective. And then we need to look at their treatments. We need to understand what their current medications are and come up with a plan if they're on a therapy that needs to be discontinued prior to pregnancy. Don't forget complementary therapies. These are things we should be asking about. And really, if we do need to make a change or optimize, at a minimum, they need to be stable at least 3 months prior to considering conception. We also want to get them caught up on various health maintenance aspects, smoking cessation, screenings, et cetera, that won't necessarily be done during the course of pregnancy. And then nutritionally, make sure that they're on appropriate supplementation, not only their prenatal vitamin, but are they getting enough iron, vitamin D, B12, et cetera. And you can actually refer to a dietitian to help to maximize some of this pre-pregnancy. So, the big question is, what do we do with our medications? And so this was modified from a recent ECHO guideline that included some of the data from the Piano Global Consensus that Marla and I recently participated in. That really, when we think about our medicines, all of our biologics are safe. They're safe not only to be on entering pregnancy, but they are safe for initiation during pregnancy, and actually preferred. That really managing that disease activity will improve our outcomes. Corticosteroids are in yellow, in that if you need steroids during pregnancy, of course you use them. I'll show you some data using steroids in pregnancy, but you need to have an exit strategy, and it should not be they're on steroids throughout pregnancy. In fact, I'm initiating biologics during pregnancy. The ones in red are the ones we need to think about, in that methotrexate, certainly we can discontinue. We often only use it as concomitant therapy in Crohn's disease, but the JAK inhibitors. The JAK inhibitors in particular are obviously used for our patients with more severe disease. I have a growing, very large cohort of young women on JAK inhibitors who are interested in pursuing pregnancy. And we have to be thoughtful about this, in that in animal data, there are some evidence of fetal malformation and other concerns, and it's a small molecule. It is immediately active, and the fetus is immediately exposed. So in an ideal world, we would not have a pregnant woman on a JAK inhibitor during the first trimester, but we need to be able to come up with good strategies to minimize that exposure. But I would also argue that the most important factor is actually controlling that mom's disease activity, so that in some instances, and I'll show you the data, we have data on JAK inhibitors used during pregnancy in those scenarios and have not seen significant signals in humans. That said, the numbers are very low. For ozanimod, I would argue that this is used in much more moderate disease, and so this is less of an issue. We'll be able to switch them to a biologic that is safe during pregnancy. So again, biologics are very safe. The small molecules, we need to think about an alternate option. So emphasizing the data that stopping a biologic during pregnancy really worsens outcome. As many of you likely know, prior to the most recent European guideline in Europe, it was relatively standard practice to stop medications at 24 weeks with the thought that you could minimize exposure to the fetus of the biologic. But in fact, what you saw in the graph on the right is that those who stopped actually had worsened outcomes, and in fact higher rates of preterm birth. And preterm birth is the #1 predictor for complications for the baby, whether that be infectious or otherwise. And so it was actually those who continued on therapy on the left that had a significant reduced odds of complications of pregnancy. So this leads me to the Piano registry, which Marla and I have been a part of. Uma Mahadevan leads this registry, and it's been such an amazing resource for pregnancy outcome data. This has been ongoing since 2007, and it enrolls pregnant women with inflammatory bowel disease exposed to any of our agents. And one thing you may or may not know is anyone can enroll. You don't have to be at a site. And so really we have the ability to remote enroll any of your pregnant patients you see in clinic. And so they can go to pianostudy.org and we can take it from there. But these are the original mainline outcomes of the study, where we had 1,490 women with 1,431 live births. We had individuals on no therapy, individuals on immunomodulators alone, on immunomodulators combined with anti-TNFs, and of course on biologics alone. Now this was predominantly anti-TNF data at this time of the publication, but essentially what we found, there were no increased risks of congenital malformations, no increased risk of spontaneous abortions, no increased risk of preterm birth or low birth weight. But interestingly, in those infants who the mom had a flare during pregnancy and in fact had preterm birth, those infants had an increased risk of infections over that first year of life. We found that the only factor associated with spontaneous abortion was active disease. So controlling that active disease becomes important. And then the children were followed for developmental milestones, and there was no negative impact of drug exposure on any developmental milestones for the children. We then subsequently published the data on vedolizumab and ustekinumab with essentially similar findings, where there were no adverse outcomes, and that in fact staying on therapy improved outcomes for these individuals when you compare them to individuals not on therapy. So it's that factor of controlling active disease. So this is a lot of words, but the summary is these are the data for JAK inhibitors in terms of human data in pregnancy. So from the Octave clinical trials, there were 34 pregnancies, about half and half women and men with exposure. But I think one thing that we have to have with a grain of salt is any of these registries from the trials, remember they were getting pregnancy tests every month. So at most, they would have had 5 weeks of exposure. So this is very early exposure with then discontinuation of therapy. But essentially, the rates of everything from spontaneous abortion to kind of congenital malformation, et cetera, were comparable to the general population. For upadacitinib, there have been 128 pregnancies from post-marketing as well as from trials. The mean in utero exposure from the trials was, again, only about 5 weeks. But again, the rates of live births, spontaneous abortions, et cetera, were comparable to the general population. There was one report of a ASD in a patient exposed to upadacitinib. And then in post-marketing studies, again, we see outcomes somewhat comparable to the general population. Remember, these are caught very early in pregnancy, so you see a higher rate of spontaneous abortion. That said, no one is recommending that we continue JAKs during pregnancy. The recommendation is to stop JAK inhibitors at least 1 week prior to conception if possible, due to these limited human data. And perhaps during the discussion we can talk a little bit about what our strategies are. But for me, it's often trying to start something they haven't been exposed to, like an IL-23, keeping the JAK inhibitor on board until the day before they're interested in starting for a pregnancy, and then trying to avoid that JAK inhibitor in the first trimester, where I use it as a safety if they relapse in second and third, that I could potentially add it back. But this is complex, and it's an area where we don't have a lot of data. But I think we need to start thinking about this, because as our JAK population grows, people who've previously failed TNF, we're going to see them wanting to become pregnant and have to really provide them with the highest level of data. For ozanimod, these are the published data from the development programs for UC and MS, a total of 78 pregnancies. In these as well, data were comparable to the general population, but again, it was really just that upfront exposure of 5 to 6 weeks and then discontinuation. The S1P inhibitors actually need to be stopped in a longer time frame prior to conception, just because of their half-life. So these should be stopped 3 months prior to conception. So when you're doing your preconception counseling, they're very obvious choices of agents you could switch someone on an S1P receptor modulator to, including many of our biologics. So, as I mentioned, in piano we also looked at corticosteroids, but it's very hard to tease out corticosteroids from active disease. You don't put someone on a corticosteroid unless they have active disease. And so you can see that those steroids were associated with more preterm birth, low birth weight infants, NICU stays, but also I think that's heavily influenced by the active disease that the steroids were started for. But I think the take-home message is we shouldn't be starting steroids and continuing them on steroids, feel comfortable starting a biologic during pregnancy to control that active disease. Just very briefly, biologics are safe when a mother is breastfeeding. They don't adversely affect the infant outcomes. We even looked for rates of infection at 12 months in those breastfed versus not, which were comparable. That milestones, developmental milestones, were comparable amongst those breastfed and not. So when they are on a biologic, it's a big protein. It has very small excretion in breast milk. It is there, but this does not have clinical impact for the child. So we encourage breastfeeding on biologics. This is not the case on the small molecules. And if you're on a JAK inhibitor or an S1P receptor modulator, you should not breastfeed, because that actually would there'd be greater exposure for the infant. So we also know that immunomodulators and biologics do not impact vaccine response. This was a nice study out of Piano again that demonstrated no difference in antibody titers against our common vaccines that are given to children in the first year of life. And we know that those developmental milestones, everything from personal and social development to cognitive development, is actually comparable. In fact, Uma and I were joking when we did these analyses that children exposed to TNFs were actually better on some of the kind of developmental milestones. And so this is not something that we need to worry about in terms of the development of our children. You know, the other factor that particularly here in the US, where we have short maternity leaves, comes to play is Does the fact that the child was exposed to a biologic in utero impact parents' decisions on whether a child should go to daycare? So we felt this was important to study. And when you look at children who went to daycare versus not, as is true in the general population, there were more non-serious infections in those that did go to daycare, but there was absolutely no difference in serious infection. And then when we looked specifically at those individuals exposed to biologics versus not in utero, there was no difference in terms of infection rates, whether they went to daycare or not. So in essence, the treatment choice during pregnancy should not impact whether a child can go to daycare. And so just two final recommendations that are kind of the newest, hot off the press recommendations from the Piano Global Pregnancy Consensus. We had individuals from all over the world representing every continent, except Antarctica, where IBD is cared for, to really help us to come up with international recommendations, many of which are those that I just discussed and showed you the data for. But there are two new recommendations that I think you could take home to your practice today. So women with inflammatory bowel disease actually have an increased risk of preterm preeclampsia. The autoimmune disease itself drives this risk. You can see this not only in the Danish National Birth Cohort, where women with IBD had a hazard ratio of greater than 2 for development of preterm preeclampsia, or in the National Inpatient Survey data, where the odds ratio was 1.5. So in essence, our patients have a risk factor if just having IBD alone. And importantly, there was a very large study called the ASPRE study that was a randomized controlled trial that looked at individuals with risk factors for preterm preeclampsia and they randomized them to low-dose aspirin versus not. And essentially, if you were randomized to aspirin, you had an odds ratio of 0.38. That is good for protection from development of preterm preeclampsia. The aspirin was started at less than or equal to 16 weeks. And importantly, when you look at retrospective data, aspirin, unlike other NSAIDs, is not associated with an increased risk of relapse or active flare in patients with IBD. So we suggest that pregnant women with IBD take low-dose aspirin to prevent preterm preeclampsia, and ideally this should be started at less than 11 weeks gestation to prevent that preterm preeclampsia. We don't have a 150 milligram dose of aspirin in the US, so they take 2 baby aspirins, 81 milligrams, and I've started recommending this to all of my patients. Another new recommendation from the Pregnancy Global Consensus, and this is new, and hopefully you can take it home to your practice, is that there have been some very nice work out of Canada that has looked at going ahead and providing rotavirus vaccine, which in the US is the only live vaccine recommended in that first 6 months of life after delivery, when in theory, children exposed to moms on an anti-TNF may still have a level of an anti-TNF in their system. And essentially, this study showed that it has no adverse outcomes, that rotavirus can be offered to infants exposed to anti-TNF agents in utero. So this is a much simpler message for our pregnant moms. If they're in the US, they get every vaccine for their child. There's nothing we need to counsel about. We don't need to withhold rotavirus vaccine anymore. So in conclusion, IBD diagnosed during the childbearing years is common, and there are many misconceptions. And I would argue that we are responsible for helping our patients really understand the data, that preconception counseling can improve knowledge and reduce complications. Remember that biologics are safe and active disease has complications. A healthy mom equals a healthy baby. And knew that IBD moms are all at increased risk for preterm preeclampsia, start a low-dose aspirin by week 11, and that rotavirus can be provided on schedule to babies exposed to biologics in utero. So thank you.
Thank you so much, Millie. Just to recap, actually one of our MFMs actually is giving low-dose aspirin for the last year in our patients, even without the evidence promoted by Piano. So they get 162 milligrams of aspirin for every IBD patient who's getting pregnant. You work with a particular MFM person. So any questions in the audience before you go to the case presentations? A lot of evidence we talked about. So let's go to the case presentation, and then we'll probably have more engaging discussions. So we'll start with the case. Again, most of these are tertiary quaternary referral cases, so it's just going to be a lot of consensus differences in each one or two. So we're going to just come up with a final discussion of what we need to do. So a 50-year-old female with past medical history of ulcerative colitis, presents with worsening symptoms of UC, obviously has been having disease for the last 8 years. Initially was tried with mesalamines and prednisone, eventually was on infliximab for 2 years, had good response, and secondly loss of response, and then had adalimumab for a year, and then again, second loss of response. So, and then she tried 2 other biologics subsequently with primary non-response, basically not respond to the medicine. Has been on prednisone on and off for the last 2 years before she was referred to us. I mentioned to you extensive UC for the last 8 years. Nothing else significant otherwise, not a smoker. So currently when she was presenting to our center, she was on ustekinumab every 4 weeks along with prednisone to help manage her symptoms. This is her presentation, physical exam, obviously significant for low hemoglobin, albumin being low, elevated CRP and calprotectin. Not surprising, infection testing is all negative, including a C. diff PCR. That's the QR code in terms of plan, but this is a FlexSig. Obviously, the patient just had a colonoscopy before 6 months, so we didn't want to do a colonoscopy again. Did a FlexSig. Obviously, anybody can say it's Mayo score 3 based on presentation. Pretty active disease, extensive from the descending colon all the way to the sigmoid rectum. So pretty significant disease present in the patient with ulcerative colitis in spite of ustekinumab and prednisone. So this is the finding you see. Obviously, the patient has got multiple biologic failures, almost 4 biologic failures on prednisone. So 4 different options you can offer. Either you can refer to a colorectal surgeon, I think time for a colectomy. She's 58 and going through too much. You can think about IL-23 inhibitors as an option. You can switch to a JAK inhibitor, either for UPA, or you can consider a clinical trial recruitment in our center. So audience, do you want to vote for this? Who wants to go with surgery as the first option?
The
I want
surgeon.
them to talk to the surgeon.
Yeah, they should meet a surgeon automatically if they require more than 2-3 biologics. In my opinion, they should talk to a surgeon because it's not going to happen today or tomorrow, but it's going to happen at some point down the line. They should at least have a discussion. So, in our practice, we routinely use that. I think the audience are switching to UPA, which is JAK inhibitor. And that's not an unreasonable option, but they still should meet a surgeon just to get an opinion and what they're getting into if surgery is needed down the line. So she started on UPA monotherapy, as expected. Obviously, anybody else have any differences other than meeting a surgeon? Would you have started UPA or IL-23? What are the options you choose from?
I just want to comment that
Yes, yeah.
as opposed to Crohn's disease, the ulcerative colitis IL-23 trials did not include ustekinumab failures. So we actually don't have any, as opposed to for RIZA, for example, or in Crohn's, guselkumab, it's head-to-head against Ustek, but don't confuse the 2 diseases right now. So although, of course, we may think that maybe, I'd venture to say I'm not 100% sure, that the 23s in UC are that different than IL-12/23. I need to be proven wrong. But I just wanted to make that point because that nuance is often not
And I
discussed.
think there's another nuance here too, Marla. I think, and I don't want to put words in your mouth, but in Crohn's disease, IL-23 is still work incredibly well post-TNF. Like I would definitively go to that. But in UC, it's not as robust. Like IL-23s are not the be-all and end-all after TNF. And so in that scenario, I really tend to go to UPA unless there's a contraindication.
I mean, Bruce, you showed the delta in the refractory when you had your slide of all the 23s. It was like 13%, 15% in
Not
refractory.
as good as
Yeah.
In
what we do
the
expect
TNF
with
exposed,
UPA.
yeah.
Yeah, and I agree with it. I think for UC, we don't have any difference with this IL-23 versus IL-12/23. I think you don't have any evidence at this point of time. So when a patient's already failed UPA, I think it's reasonable to put a JAK rather than go to IL-23 at that point of time. So the patient started on UPA, actually symptomatically improved pretty rapidly. After 4 months, she's off steroids, stool frequency improved, rectal bleeding improved. Unfortunately, around the time period, she was diagnosed with intraductal carcinoma of the breast at the same time and required mastectomy, but it's very early stage 1, they said, and did not require any chemotherapy. Does it change your management at this point of time because the patient had cancer? Would you do anything different, audience-wise? I'd like to maybe call Bruce. Do you do anything different at this point of time?
Yeah, I mean, it's a risk-benefit discussion. There's not very much that we know about the risk of evolution of cancer once it's diagnosed on the upadacitinib. I'm not thinking that breast cancer is from the upadacitinib, but we can't really prognosticate how that will affect the course of the cancer or its treatment. So I think she has limited options. If it's not UPA, it's going to be probably colectomy for her because very likely stopping her UPA will lead to recrudescence of her.
Marla, do you have any comments on that?
Yeah, just a reminder, going back to the oral surveillance study, which you showed, Bruce, the risk factors with TOFA, the malignancy was lung cancer, actually, and in the TNF group, it was breast cancer. So it's just to always contextualize that no one's confused about what was the malignancy, top malignancy with the JAK aside.
In a population
smokers.
highly enriched with smokers,
In
right?
smokers, that is correct.
Smokers, yes.
Yeah, no, so I think a couple of things. I think Bruce is right. There's no, you can't make a direct line. But Millie, breast cancer, IBD, just alone, any risk?
Just alone, no, there's never been shown to be any increased risk of solid organ tumor. And so, I've had this patient's twin that I've taken care of, and we have continued the JAK inhibitor. I agree it's a shared decision-making discussion, but the next step is colectomy. And so you just have to be open and honest, and you have to share the data that we don't think there's any data associated with solid organ tumor, and she's going to be in an intensified monitoring process with oncology. But I don't think there's a contraindication to continuing the UPA, and in fact, I would.
Bruce, what about Vega in a patient who's got, remember that's a TNF plus, even though you said solid tumor, she had seen 2 TNFs. She hasn't seen a 23, and going back and ignoring everything I just said about there's no data on it, on IL-12, 23, going to 23. In someone where you're talking about colectomy versus not, let's say UPA was off the table,
Off
or
the table,
she...
for some
Combo
reason.
therapy of
Would
anti-TNF plus anti-IL-23. I think you have to remember who went into Vega. Not highly refractory patients. These weren't patients who had failed anti-TNFs. They hadn't failed ustekinumab. They might have failed vedolizumab. That would be it. So that's not this patient. So the jury's out. I think there's reason to think combination could be more effective. So far, the safety data look excellent. But again, 0 safety data with regard to malignancies. So I don't know.
But Marla, we'll learn that from Duet. Yeah.
So the other consideration is, can you drop the dose of UPA? If you're stopping or starting is okay, but do you drop the dose to 15? That's another consideration from 30. Or again, going back to the option of surgery, just because of the concern of safety with the patient, do you do anything different? Audience want to vote? If you guys are interested. Still have energy to vote? Yeah, towards the end of the day. Yeah, so it's 50-50. Okay, so people try to drop the dose. So we did not drop the dose. We continued the same dose because I have never dropped a dose to 15 probably in my practice for UPA, maybe in one patient who was doing in deep remission. And I'm really worried about dropping a dose because I always feel like the flares are much higher. And in my patient population, I would say 50% of patients actually had dose escalation to 45 back on from 30. So I rarely do 15 in my practice, at least, very, very rarely. Just because of the referral base we have, but it's always an option. We discussed with the patient. The patient elected to go at 30 again. I did not drop the dose or increase the dose back. But after surgery, she had some complications. She had antibiotic using surgery, had some mini flares after surgery, but she recovered a little bit. After surgery, her biomarkers were actually great. The best you can imagine in the last 7 months since treatment started. So overall, she's doing okay. And this was her colonoscopy in April, I think. And she presented. This was her, obviously, cecum. TI obviously looks normal. Come back. Obviously, see ulceration in the cecum area, ascending colon. She had pancreatitis prior, and except for that area, I keep coming back. All the inflammation has improved dramatically. Mayo score 0, rest of the areas, I think, as long as I keep coming in. But as I keep coming back, I see some subtle abnormalities in the mucosa. Obviously, you see some lesion there. Which are obviously polypoid, the polypoid lesions, the 12 o'clock, 11 o'clock position, and one at 2 o'clock position. And if you look at the margins, see the margins are they look very simple looking at it, but they're very extensive. It's actually quite big, almost 8-9 centimeters in diameter if I carefully mark it. During the procedure, went all the way around the entire area. Again, this was never reported on previous colonoscopies, just outside, so I don't have the actual comparison a year before this colonoscopy, but this is what I see on treatment after 6-7 months of treatment with UPA. So we obviously find this lesion and keep coming back along the way.
Patient?
This location is transverse colon, I believe, transverse.
Transverse colon.
So let me keep... Coming back, I mean, the mucosa looks great, improved dramatically. Again, I see one more lesion, and this is in the descending colon, but this is much smaller compared to what it was before. But I see the lesion is actually non-polypoid again. I see the lesion is extensive beyond this area. Actually, it's not just here. It's actually a both polypoid and non-polypoid component both. So pretty extensive lesion. It's not very small, but can be treated, could be fixed endoscopically. It's possible, but so these are the things we see on the colonoscopy and follow-up. But if you look, the response has been dramatic, except for the focal area on the right side where the response, the inflammation was there. Responded really well to UPA. Comparing the sigmoidoscopy 4 or 5 months before and now, you see a dramatic improvement in her exam. So the rest of the colonoscopy looked fine. I mean, obviously some erythema here in the sigmoid area. But this is what I see after 6-7 months of treatment with UPA in a patient with breast cancer. So I resected the lesion I saw, the polypoid lesions. I did biopsies from other areas. So this is our path. The biopsies from the path ulcerated area came by high-grade dysplasia. The 2 lesions I resected, one was tubular adenoma with low-grade dysplasia, the one which was actually in the descending colon. The one in the ascending transverse colon was tubular adenoma with high-grade dysplasia, resected area. Biopsies around the lesion were negative for dysplasia. So this is where we are at this point of time. So at this point, what do? Do you go to a surgeon again, finally? Or do you increase the UPA to 45 and repeat a colonoscopy again? Or do you increase to 45 in 3 months, or continue at 30 and repeat a colonoscopy in 3 months?
100%.
I think I'm referring to Shen to remove her colon bit by bit.
Yeah.
So boys should not touch this patient, okay?
But Uday, this is not uncommon. I find these patients where you finally get them healed, and that's when you finally see this. And so if you did a study in this in claims data, you'd see, oh, they're on UPA, and then they get, dysplastic lesions, but it's because the UPA finally healed them, and you're seeing what you couldn't see before. And so it's not uncommon.
I have probably 8 or 9 patients in the last year, exactly similar find. I don't want to put all the videos for everybody, but I get referrals for low-grade dysplasia, and I heal the colon, go back in 6 months, almost always find cancer. So, it's just, that's what we've seen. So, Bo, you want to have comment before we?
I'm glad you didn't do ESD.
So, ESD, in my opinion, has no role in IBD, in my opinion.
Correct.
No role in IBD.
Correct.
And I strongly discourage it, because there's no role in IBD at all. Because IBD lesions are not non-IBD lesions.
Because there's a common mistake the endoscopist made. Okay, we have that tool, it's liftable, and then you do the ESD. Actually, EMR is reasonable. You have the well-demarcated, totally liftable lesion, EMR, assuming the surrounding mucosa is normal. So this is not all the things you have, that's the golden hammer, everything's like a nail. So that's great, glad. Other things you do, it is, nowadays, a J pouch is popular, right? Actually, the J pouch is going down in some of the Europe, the Northern Europe, and then England. So they elected to do ileorectal anastomosis, especially for young women. So you may offer, if the rectum make sure when you do before the surgery, you need to document it's an anal rectal function, and the rectum is distensible, it's a floppy distensible, it's very stiff. Then you need a J pouch. If the rectum is still useful, if the patient really liked to have that become pregnant or whatever, you may offer the ileorectal or ileosigmoid anastomosis. But even now the laparoscopy stage, sort of so the decrease risk of the fertility risk, but still it's you give this patient 2 options. And then I'm a big fan of the dye-based chromo endoscopy. So I think it's better than the narrow band. So I would do the dye band, and then maybe you may have the additional hidden regions, especially in the rectum.
So, this patient elected to finally actually had colectomy done. Interestingly, she had stage 2 colon cancer in her pathology. So I think it's very important. This is a good teaching point that I think meeting a surgeon early is important when a patient has got multiple failures. And evaluating the colon carefully is very, very important. I think it's in an IBD patient.
Uday, did they do the mucosectomy or not? Is it controversial?
This patient now has stage 1, has 3-stage surgery. She just finished a total colectomy and ileostomy. So, not
would
yet.
it be yes. So the question it is, if you have a pre-colectomy dysplasia, any dysplasia in the rectum, you have to do mucosectomy. But if the dysplasia somewhere else, like the middle of the colon, right side of the colon, and the recommendation is you may not need to do patient dysplasia.
I think we're way beyond time. We'll try to go to the next case quickly. So any questions before we go to the second case? So the next one is a 70-year-old white male. He's an avid golf player. He was a pro golf for a while, and he came from Naples. He presented with a long-standing history of Crohn's. Obviously, a significant history of Crohn's for a long time. Again, it's a uniformly distributed, pretty much infliximab, adalimumab failures, vedolizumab, primary non-response. Started on TOFA off-label way back because at that time UPA was not available. And then he had minimal improvement in symptoms. And then his primary GI there locally started him on ustekinumab. Had partial response along with prednisone for 20 milligrams because he wanted to golf and he didn't want to take up surgery and a bag to deal with his life, with his golfing life. So that's what he had, and then he was referred to us at that point of time. Obviously, Crohn's colitis. He'd actually had a history of sigmoid colectomy for diverticulitis prior to that. But another history otherwise, not a smoker, interestingly, again. Similar to last patient, ustekinumab and steroids continue to have continuous symptoms. Exactly similar to the last patient, significant hypoalbuminemia, elevated biomarkers, anemia. He has met with surgeons in Cleveland Clinic, Florida, but did not elect to surgery because he said, I want a third opinion. So he came here to us for another opinion. So this was his colonoscopy when he presented it to us. Obviously, this is the cecum, extensive inflammation throughout the colon. I'll try to move faster if we can.
Did you see a scope on TOFA, even though it appeared he wasn't clinically improved?
I didn't see it from the GI. They didn't scope him on TOFA. He had partial response on TOFA, but he didn't have a response, and then they switched him to ustekinumab at that point. But this was his presentation initially when he presented to us.
Why the ileocecal valve was so patent?
Patulous, yeah.
Like patulous, like fish mouth?
Yeah.
So liver issues, right?
Yeah, so they referred us Crohn's disease because of a history of sigmoid colectomy. I thought it was diverticulitis related, but they think the stricture. I don't know whether the stricture was Crohn's related or diverticulitis related stricture 15 years back. So we don't know the exact chart of exact pathology report from that point of time. Again, this is going back to the question of whether to do surgery in this patient. Again, if you don't have a clear diagnosis of UC or Crohn's, do you offer endoileostomy? He's 78 also. He's not a good functional person for a pouch. So endoileostomy, or you can switch to IL-23. Again, you can obviously add an immunomodulator on top of ustekinumab. I don't know if there's any evidence for it, or consider a clinical trial, or switch to UPA, just to discussion.
Let's say switch or add, just because of where we're going in the field.
Yeah.
If he had some response, if he had none to Q4, then I'm not sure it's helpful, but.
He was on prednisone to the entire time period for the last 2 years, even on TOFA, even on ustekinumab. I think if you have time, maybe give like 5 seconds to click on the options. Switch to UPA. I think it's been a universal thing. Diffractic is, UPA is probably the last resort for us in a tertiary referral center. So started on UPA, and interestingly, he dramatically improved. I mean, you probably have 100 success stories similar to all of us have. Good response, improvement in CRP and FCP. When he dropped the dose of 30 from 45, his symptoms flared up within like 3-4 days, and his FCP elevated pretty rapidly. So I had to go up to 45 again. Obviously, what next? I think in interest of time, we'll just go to the next part. I went back up to 45 just because he was failing on 30 rapidly and increased fecal calprotectin at that point of time. So, and then he did well. We followed him up with the repeat colonoscopy on follow-up, and this was exact repeat colonoscopy after 6 months of treatment. I biopsied out the lesion, all came back negative. No dysplasia. And I always do blue light and LCI imaging. I like the Fuji endoscope. I don't like Olympus anymore routinely for my IBD patients. So I use LCI and BLI, blue light imaging, for dysplasia for every patient. I don't use chroma for everybody, but I use like a virtual chromo pretty much. It saves time for me. And
that's a lot better.
Yeah, it was a biopsy, just came back. This is actually a lesion I removed, a small lesion, I resected it. But I removed everything, all the biopsies came back negative, no dysplasia, and the response is amazing. He endoscopically in remission. The biopsies actually from the right side showed no active colitis, left side showed some active colitis. So histologically, pretty good response as well. So he was traveling to Europe after this because he was so happy, traveled to Europe on a flight, and developed a new onset DVT, and actually had a PE as well. So he went to a place in Europe, and they stopped his UPA, and then they put him on steroids to avoid a flare, like a low-dose steroids, 20 milligrams, and he came back to US after that. He was Eliquis and stopped UPA for 2 weeks before he presented to us. I think we'll start with Marla, who's most aggressive. I like her a lot. So what do you do next for this patient? Yeah.
You mean personally aggressive or just when it comes to management? Yeah, I was going to ask Millie whether if you think the data that was presented at DDW last year, that as long as they're on anticoagulant, would you be willing to restart the JAK? Because that was sort of the data that was presented. What does the epi data suggest on that?
So I think this would absolutely have to be shared decision-making yet again, like Bruce was mentioning, risk-benefit, but there are observational data that obviously once you're on Eliquis, you're most likely not going to get a recurrent DVT. And obviously in this gentleman who's 78, there can be some significant complications associated with colectomy as well. And so I personally would offer him the option to go back on the UPA and stay on the Eliquis.
Would you drop the dose to 30 just because of DVT? Is there any evidence for dose escalation or dose
I don't
change?
think we have any dose-related data that increases the risk of DVT.
There is with TOFA.
With
as I
TOFA.
showed.
But not necessarily. But I mean, it's
Only.
probably
Extrapolating to UPA.
Only if they had a prior history of VTE, and even the TNF was a risk factor. So even the whole VTE story from the 1133 is complicated
Very complicated.
to understand. So I think most of us would be willing to put him on the dose that worked as long as he's on anticoagulant.
Yeah, as long as he understands that
Risk.
anticoagulation is still not perfect.
So we discussed the risk benefits. Patient said, I'm not going to cut off to OPA. So he went back on UPA after shared decision making. And we actually continued the 45 milligrams for 2 more months. And then after a long discussion, I dropped the dose to 30 because he's doing so well. And I just scoped him last week. He's still in endoscopic remission after a year of treatment at 30. So he's doing well. He's off Eliquis now. He's also off Eliquis, so...
He has a trigger, right?
What is
Flight.
it? It's trigger, after transatlantic
No more long
flight.
flights.
So
No flight.
the hematologist said to stop it in 6 months at the maximum. So he's off and he's on UPA 30 milligrams and he's doing well. So that's...
Oh gosh, I'm not sure I would have stopped the Eliquis though.
I know, that's what I
That's
said.
the one thing I might have.
What is it?
I might have continued
to
the
Eliquis.
Eliquis.
Yeah, but hematologist said, I think we have a clear trigger. They did all the workup. They didn't have any, obviously, etiology. They said they are pretty confident. Usually, I have more conservative hematologists all around. They said, I think, given his age, 78, 79, they said it's not worth to put him on Eliquis long term with no clear benefit. So they stopped it after 6 months.
To your dose response, just one quick teaching point. There are some of the side effects of JAKs that are dose dependent. The acne definitively. If someone is having acne at 45, it'll get better if you go to 30, and even better if you go to 15. And then the other one is the lipids that you see that once you drop dose, their lipid abnormalities improve somewhat too. So.
And Zoster.
And Zoster,
Zoster,
yeah.
the biggest risk factor, yeah. Yeah, the last case, just to wrap up quickly, again, J-port surgery for UC, 1992, and then actually had chronic symptoms, had a redo pouch surgery after that because of pouch failure in 2019. Both surgeries were done in Tennessee, I believe. He came from Tennessee to us for a third opinion. He has tried, before his surgery, he had 2 biologics before he had pouch failure. After his 2019 surgery, his second J-port surgery, he had worsening complications of rectal pain and diarrhea. He had like a small fistula, perianal fistula, and some inflammation in the pouch. So they treated him as Crohn's disease, like phenotype of the pouch locally. And they started him on Vido because he had failed 2 anti-TNFs before in 2020, and then had not much response. They switched to ustekinumab in 2022, and then he came to us afterwards. Obviously, he had significant rectal pain and ongoing symptoms of diarrhea and discomfort, not responding to antibiotics. Nothing else significant in the history. In the interest of time, we'll just keep going. This was his pouchoscopy. As soon as I go in, I see a lumen to the left of mine. This was what is reported as a perianal fistula on the imaging and from outside. And this is the staples from the previous surgery. And obviously, look at his pouch. His pouch looks very healthy. I don't see any evidence of Crohn's of the pouch. I went to the afferent limb of the J pouch, and the afferent limb looks healthy. I went to the area of the ileostomy closure, and I don't see anything concerning. It looked very healthy all around as far as it went. So this is what we see. In interest of time, we'll try to fasten the video. But basically, what I saw was a normal pouch, except for this questionable fistula he was referred to as and referred as Crohn's of the pouch on treatment with no improvement for the last 3 years since surgery. So what do you do for this patient? So either you can think about his failed ustekinumab, so you can think about IL-23 for treatment for CD of the pouch, or you can start UPA, or you refer to course if anybody does a third redo pouch surgery, which is unusual, which is I don't think any left for him, or you can do a permanent pouch excision, an ileostomy, just because he's not doing well in overall quality of life. In the interest of time, just if anybody wants to click before we go to the next step. Bo, you want to comment? Because it's your...
I was going to say, the other answer should be Bo.
Yeah.
So the first one is like a redo pouch for chronic pouchitis. You never do it. Because the study showed, actually, our study showed that there are 5 patients with chronic pouchitis redo. All of them come back. So you never redo pouch surgery for chronic pouchitis, number one.
Tennessee.
Number 2, it is after redo, you lost piece. My favorite piece, EMZ zone, which is a cuff. Now, what happened, you see that this one has no cuff. It directly has a moist organ on the anal transition zone. Then you have an anal gland infection. Look at this one, right? The perianal fistula, but the pouch body is normal, small bowel is normal. It's moist. And plus, there's one piece show the pouch prolapse. It's like a meatball on the outlet. So all related to redo surgery. Medicine won't work. If medicine only works a little bit antibiotic because those patients has a bacterial overgrowth, but you have not solved the problem. Third redo, even worse. So what happened to probably this patient, perfect candidate for cook pouch.
What about sinusotomy?
Ileostomy.
Sinusotomy.
Sinusotomy, but this already had you lost the anal transition zone, and you lost the cuff. Mr. Putin invade.
Yeah.
And while this patient does not have inflammation in the prepouchilium or pouch where you would actually start UPA, I do want to point out that UPA is a controlled release, and in an individual with a pouch, we have not seen good response. I think it's an absorption issue, and that if you're going to use a JAK in the pouch, you need to have a strategy, whether it's Imodium right before the UPA. There's some data surrounding trying to figure out how to open the capsules and things like that. But I frankly, in my practice, if I'm using a JAK in the pouch, I'll actually use TOFA because it's more immediate release, so just something to think about.
This patient also a high risk after redo pouch surgery had the pelvic floor dysfunction.
Yeah.
Or the paradoxical.
Absolutely.
Yeah, very
Absolutely.
common. It's like you can do this all the anti-inflammatory, but have not solved the structural and functional alternative obstruction.
Yeah, he's not doing well because of medicines. I thought the medicine will heal him. I completely agree.
Now, if you directly convert to the permanent ileostomy, right, you already invested, say, buying the stock too high price, twice the surgery, then go back to the stoma. But the stoma for failed pouches, stoma side complication, at least 50%. And after stoma, do you leave the pouch in, which is the kind of diversion pouchitis and diversion associated stricture. But if you remove the older pouch, excess older pouch, then there's 30 to 40% of people can have the persistent perineal sinus. There's a hole there, and with the older discharge. The life is not good. And then in addition, if you remove the pouch, one of the small bowel will be dangling down into the pelvis, make the U shape of the afferent limb, causes partial small bowel obstruction. So he's stuck. The best one for if you really quality of life would be like you need to convert to the cook pouch.
Yeah, we had probably 3 or 4 patients who have done K pouches for refractory intracutaneous fistula, post-surgical leaks from J pouch, and this patient as well, who have done well with K pouch. So K pouch is a great option if you think about it. It's like a continent ileostomy. It's very easy to manage. It's a good option to think about for patients with refractory pouch issues, post-surgical related pouch issues, basically. Yeah, I think in the interest of time, I have to wrap it up because we're way beyond the schedule, but thanks for all people who are staying on beyond the time limit. But if any other questions from either of you, any of the audience? Thank you so much for all the faculty. Amazing. Thank you so much. All right, good afternoon, everybody. Sorry for the delay in the lunch. There were some issues in the backside, but hopefully everything is resolved and we'll get started because the next session starts at 12:30. So to wrap it up, this is again a non-CME talk. So it's important to know that it's not a CME event, but it's going to be talking on guselkumab and other options for moderate to severe ulcerative colitis. So we just learned a little bit about this. I know we have a lot of options available for treatment among the IL-23 inhibitors, and Tremfya or guselkumab is one more option available for patients now approved for both for treatment of moderate to severe UC. So we'll go to it. Obviously, present we have Janssen in this talk. So we'll just talk about how this drug works, Tremfya or guselkumab. How does it work in ulcerative colitis? We'll talk about the dosing options. We'll talk about the study design, how it was designed, and how this efficacy data comes up. And we'll, towards the end, talk about the safety data of this drug and how it be positioned in the treatment of ulcerative colitis. So we have a lot of IL-23 inhibitors available at this point of time. But guselkumab is unique in the sense that it's a dual acting. So IL-23 inhibitors basically bind to the P19 subunit and help inflammation. But guselkumab also, what it does is it binds to CD64, which is actually the cell which actually produces IL-23. So it's a dual action mechanism which promotes its efficacy and decreases the IL-23 in the cells. So the two mechanisms I mentioned. So one, it binds to the freestanding P19 subunit of IL-23 and inhibits IL-23. And the second mechanism is, because it's fully human antibody, it binds CD64 on the surface of the monocytes, and these monocytes are the predominant source of IL-23. So it binds to it, decreases IL-23 production from the monocytes by binding to it, and also attaches to the free IL-23 to decrease production. That's how this drug works. It's kind of unique in that way. And see, this shows that it actually binds to IL-23 and decreases the IL-23 production from the cells here as well. Induction, that the regimen is very straightforward to use. All of you are well aware of IL-23 inhibitors. It's the IV induction regimen followed by the maintenance therapy. IV induction is 3 doses of 200 milligrams at week 0, week 4, and week 8. For maintenance, it's very flexible. There are 2 different options approved by the FDA for treatment. Either you can use the 200 milligrams or the 100 milligrams, depending on this, and the dosing frequency is also different. You can either use the 200 milligrams every 8 weeks, starting at week 12, or you can do the 100 milligrams every 8 weeks, starting at week 16. So 2 different options. Which option to choose? I'll go a little bit about the data, what we have, to decide what we choose. But the 2 options available for maintenance. So if the patient is doing really well on 200 milligrams every 4 weeks, you can always have the option of switching to 100 every 8 weeks if needed, or vice versa if the patient is not doing well. So the data for this approved for the FDA comes from the Quasar trial, which we are a part of at Orlando Health. So patients get IV induction with guselkumab 3 doses, and then week 12 responders will get randomized to the 3 different options mentioned. One is the 200 milligrams sub-Q every 4 weeks, or 100 milligrams every 8 weeks, or they can go to the placebo arm, and they followed up to week 54. So all these patients had moderate to severe UC, and some were bio-naive, some were bio-experienced or bio-failed patients in the category. So the study design is very straightforward. All of you know pretty much they should have moderate to severe UC in the trial. They should have a Mayo, obviously a colonoscopy showing that the Mayo score is either 2 or 3 at baseline. And they previously had tried other therapies or bio-naive. Both are options available. They should not have Crohn's disease, obviously the exclusion criteria in these patients. Patients only with proctitis or low proctosegmatitis were excluded from the trial. Obviously, if you have fistula or a stoma, you cannot include them in the trial because of the presence of Crohn's. If you have severe UC requiring hospitalization and a possibility of requiring colectomy, these patients are not for outpatient management. They should not be enrolled for the trial, so they're all excluded from the trial as expected. So if you look at the overall study population, the point of interest is almost 50% of patients, more than 50% of patients were bio-naive, and almost 40 to 45% of patients were bio-failed. So it's an almost equal distribution of patient population. Extensive UC disease, what's called pancolitis, was seen around 42 to 50% of patients in this trial. And if you look at the median CRP and calprotectin, they're all very high, showing active inflammation. So it's a pretty sick population of patients which you see with UC in this trial, which got qualified in the trial. The first data we look at is clinical remission. So clinical remission in UC is technically a misnomer because you also do a colonoscopy as well week 12. So patients had improvement in the patient-reported outcome, which is actually improvement in the stool frequency and the blood in the stool. In addition, they get a colonoscopy at week 12 showing that the Mayo score is either 0 or 1. All of that encompasses the definition of clinical remission. And if you look at it, within the first 3 months of treatment, almost 1/4 of the patient achieved the endpoint of clinical remission. And if you follow these patients long-term in the maintenance study, more than 50% of patients achieve the clinical remission at year 1 with the higher dose of study. There's no difference between the 200 milligrams and 100 milligrams sub-Q. The doses, it's not different, so that's why both these doses are approved for treatment by the FDA. If you look at the question patients ask, how fast the drug works, and the data comes from the trial as well. Within the first week, you see a response, a symptomatic response. So improvement in stool frequency and bleeding happens in the first week and continues to improve as time goes by over week 2, week 4, week 8, and week 12. Usually we look at week 12 as endpoint, look at see how the patients are doing long-term in terms of response. And the response happens pretty quickly overall within the first week to 2 weeks or so. So we look at the numbers of patients, we follow them to endpoint of endoscopic remission. So endoscopic remission is a Mayo score of 0, not Mayo score of 1 as improved in the clinical remission area. So Mayo score of 0 is what endoscopic remission means. Our 34% compared to 15% placebo's endpoint, which is significant, the p-value. But if you're bio-naive, the number is slightly better compared to a bio-fail. The number is almost 18 times higher. But if the difference between placebo is almost equal. If you look at the placebo difference, 22% here and 16% here. It's not much difference. So it works equally well for a bio-fail or a bio-naive patient to achieve endoscopic remission based on the data we have. So this is the real patient in the clinical trial. If you look at the data at baseline, a Mayo score endoscopy of 3. You follow these patients at week 44. This is what I achieve. This is the goal for treatment is a Mayo score of 0. That's the goal for treatment trying to achieve at this point of time. When you look at clinical remission at year 1, I told you earlier, 50% on clinical remission. If you look at the patients, among those patients, almost 2/3 of the patients are in endoscopic remission, basically a Mayo score of 0. Some remaining patients have a Mayo score of 1 to classify in clinical remission, but most patients achieved a score of 0 rather than 1 at the end of 1 year. So the other question asked, how long can I wait for a drug to respond? You give the drug today, you wait for a response. The time frame you look at in terms of waiting for a response. The data comes from a clinical trial as well. Usually I told you by week 12 the patients respond. What if you see the patients and the patient does not respond by week 12? Any options for those? The recommendations are, based on the clinical trial I can see, is continue the 3 maintenance doses at 200 milligrams every 4 weeks starting at week 12. And if you look at the data, more than 55% of patients achieve clinical response at week 24. So the take-home message from this slide is, if the patients are responding by week 12, well and good. If not responding, I would give 3 additional doses of sub-Q and reassess response at week 24. If the patient does not have any response by week 24, I would stop the drug because the mechanism is not mediated by IL-23. It's probably mediated by some other mechanism which needs a different mechanism or different drug to choose at this point of time. So that's probably an important message we have from the clinical trials, which is very useful for our practice. And if you look at steroid-free clinical remission, obviously you want to be in remission without the use of steroids. And more than 98% of patients who achieve clinical remission in the clinical trials achieve this without the use of steroids. So it's not surprising because you don't want to use steroids for long term in our practice. So the question asks, what dosing regimen do you choose for ulcerative colitis? Do you use a 200 milligrams Q4 or 100 Q8 is the question. And if you look at the answers come from clinical trials. So if you have extensive colitis, long term, the numbers are better with the higher dose compared to a lower dose. Again, these are not, I just said for multiplicity in the clinical trial, this is all the endpoint for clinical trials, but based on the clinical experience we have from the clinical trial, it appears that a higher dose will be responsible, will be more effective in patients with extensive colitis compared to a lower dose in those patients. Let's see. Can you move it back? Let's see. Okay. The other questions which comes up is patients who get the induction dosing. We look at the CRP in those patients. The CRP is still high at week 12. then those patients obviously need a higher dose compared to a lower dose of guselkumab. So those patients automatically get to a higher dose. And if you look at the numbers are numerically better compared to a lower dose of guselkumab. So this promotes that where I would use a higher dose would be patients with a higher inflammation burden, or patients who actually have extensive colitis where I use a higher dose of the drug in terms of getting the numbers better. So these are some of the patient scenarios where you could think of the use of this drug. Obviously, a young patient with moderate active UC and has active inflammation, Mayo score of 2. And he has tried budesonide, failed budesonide, still taking mesalamines, not doing well, and already required prednisone. If the patient has required 1 dose of prednisone, you should think about a biologic. Second dose of prednisone for sure, because the patient has already demonstrated that the patient is requiring prednisone steroid use. I should think about a biologic at that point of time. So he wants something very effective, very fast to get to quick relief, and one of the options we can offer is an IL-23 inhibitor like guselkumab. So if you look at a bio-naive patient, as this patient is, and look at the response over the first 12 weeks, you see the symptomatic response, improvement in stool frequency and bleeding. Almost more than 80% of patients achieve the endpoint within the first 12 weeks. So it's a pretty good, robust endpoint achieved if you're bio-naive. And see the placebo response splits in the first week and continues to improve along the way. So within the first week, you start seeing a response after the first infusion and continues to get better over the next 12 weeks or so. Again, endoscopic remission, Mayo score of 0, as I mentioned, at week 44 is 42% compared to 20. So 22 delta, the number is, for this patient, what I would say. And if you look at the clinical remission numbers, almost 60% of patients will be in clinical remission at year 1. Again, clinical remission is improvement in stool frequency, bleeding, and a Mayo score of 0 or 1. And if you look at all these patients in clinical remission, almost 75% of patients have a Mayo score of 0. In the endoscopic remission. So only remaining patients have a Mayo score of 1, pretty much. It's good data for that. Another patient, again, a young patient who likes to travel around and has active UC in spite of has tried anti-TNFs and has drug levels and no drug antibodies. So secondary loss of response because of what we call as a mechanistic escape from anti-TNFs. You could think about this IL-23 as an option for treatment. Again, if you have bio-experienced, a bio-failed patient, the numbers are slightly lower for response, but again, the difference is still pretty good, 61% overall at week 12 in symptomatic response. Similar to the bio-naive patient, within the first 1 week, you see splitting from placebo in terms of response splitting up. And if you look at the endoscopic remission data, 25% endoscopic remission at basically at year 1, which is slightly lower, but the delta is almost similar, 16 delta compared to 22 with the bio-naive. So it's equally effective, as I mentioned, both in a bio-naive and a bio-failed patient as well. And if you look at the data for endoscopic remission in patients who are in clinical remission, I told you 40% are in clinical remission at year 1. Of these, more than 3/5 of the patients are in endoscopic remission, a Mayo score of 0. Again, these are different ways of putting it, but the bottom line is, with all these slides, are effectiveness in both in a bio-naive and bio-failed patient. Good data for fast efficacy in the first 1 week or so in terms of efficacy. Adverse events, overall compared to placebo, I don't see anything in the induction phase, classic screening up. Adverse events, infections, serious infections, not much different compared to placebo as you look at numerically the values here in the table. Look at the data for maintenance therapy. Again, the most important thing people ask about is safety long-term for a drug which you're going to use long-term for a patient with ulcerative colitis. Again, if you look at the data for guselkumab compared to placebo, Tremfya compared to placebo, I don't see a significant reaction. Injection site reactions can be seen slightly higher with a higher dose of the drug compared to the placebo. Slightly more influence arthralgia, but not clinically significant. Upper respiratory tract infection slightly more common with the higher dose. Again, malignancy is too short of outcome to check at year 1, but if you check for that, numbers not much significant compared to placebo. If you look at the overall safety profile and treatment adverse events through week 44 in the maintenance study, in terms of adverse events, serious adverse events are slightly more common in higher dose compared to the lower dose. I'll show the next table what those adverse events are. I don't think that's related to the drug at all, the incidental findings in the patient, I think, but overall, nothing else stands other than that in terms of this adverse events. And if you look at the adverse events at a higher dose of Tremfya, none of them are class related to the drug in general. You cannot explain a stroke, fibroadenoma, gynecomastia, none of those are really significant. And this patient with adenocarcinoma had adenocarcinoma which was missed on the initial screening colonoscopy at baseline. So none of these adverse events are related to the drug as far as we know. overall in terms of adverse event. But obviously, something to watch out for if you have a patient. But in terms of overall safety, it looks very promising in terms of efficacy and safety for Tremfya. Again, in terms of safety information, we have to go with some reaction. Obviously, the risk of adverse events can happen with any drug. The risk of hypersensitivity reactions can happen with the infusion you have. There's a higher risk of infections in patients, so you obviously want to make sure there's no active infection before you start any biologic, including Tremfya. So obviously no UTI, no respiratory infections, no flu active infection before you start them on. We always check for tuberculosis as a standard protocol for any biologic, including Tremfya. No live vaccines on patients to make sure they're up to date on vaccinations. But if you look at the overall safety profile, I mean, nothing really stands out except for mild upper respiratory tract infections. Expected injection site reactions can happen, which are two things to worry about overall. So I told you there are two different formulations. Obviously, the IV induction, 200 milligrams, and then you have two different formulations of 200 milligrams and 100 milligrams in a syringe, or a pre-filled syringe or a pre-filled pen option available for patients. So Tremfya with me, I think Janssen's team can help you with all this and give access to get the drug with as fast as 3 days. That's the promise they have made to us in terms of getting the approval in patients who get delay or denial coverage overall for the drug. And in Janssen Care Pathway, they can help you with the access to the drug, get the patient on the drug, and get the patient on the infusion. So to summarize, I mean, it's an IL-23 inhibitor, Tremfya, a dual-acting drug. It binds IL-23 freely and also binds CD64 on the surface of monocytes and decreases production of IL-23. And CD64 producing cells are the main producing IL-23, although the IL-23s come from other cells as well, but these are the main cells. So the hypothesis is combination of two mechanisms may be more effective than one, although the practical clinical significance is not known. But again, we showed data for good efficacy and overall good safety for the drug up to year 1. Again, an option also available for treatment with plaque psoriasis and psoriatic arthritis. So if you have a patient with multi-system disorder with this, with ulcerative colitis, a perfect patient, think about this as an option. So that's what we have at this point, and I'm happy to take any questions you have on this topic. Yeah, the question is whether to combine them with combo therapy in patients who have inadequate response to monotherapy with IL-23 inhibitor. Again, this is outside of the realm of this talk today, but in my experience, I've used combo therapy of combination of IL-23s and other medications just because of the safety of IL-23s. We're very early at this point for combination therapy. We are in phase 2 trials. We don't have strong phase data at this point of time. So at this point, we cannot talk about it. But off-label, in our experience, and centers in the US have used off-label combination therapy, has been more successful to achieve clinical endoscopic remission in refractory patients with IBD. Yes. Yeah. Yes. Yeah. So it's approved for both bio-naive and bio-failed patients. So you could use it as a first-line treatment in patient with ulcerative colitis, or in a patient who's got failure with other medications before you use this drug as well. Yeah. So you can use, I mean, patients with moderate to severe UC. If you have moderate to severe UC in a person, your mesalamine is not doing well, you could think about this drug as one of the first option for treatment for that patient. Yes. Yeah.
Hi.
Yes. Yeah.
How about pregnancy?
How about what?
The pregnancy?
Oh, pregnancy, yeah.
Breastfeeding?
So we don't have data for this drug for pregnancy, I can say that, but based on the data for IL-23 inhibitors in pregnancy, we use all IL-23 inhibitors safely during pregnancy. If you ask me a patient on IL-23 inhibitors, I'll continue the drug throughout pregnancy in my experience. That's what we do. Perfect. Thank you so much for your time. I will have the next session after the lesson. Thank you. Yeah.